My channel. In this video I will discuss myelofibrosis. As the name indicates that there is fibrosis of the bone marrow fibrosis. Now what happens? It is a myeloproliferative disorder and there is JAK2 mutation or MPL or CALR genes mutation. JAK2 mutation is seen in almost 50% of the cases. It leads to increased production of platelet derived growth factor plus cytokines, and when these are produced then these lead to bone marrow fibrosis. And when there is marrow fibrosis, then bone marrow is unable to produce the cells and it leads to anemia. There is splenomegaly due to extramedullary hematopoiesis. It is massive splenomegaly, and there is extramedullary hematopoiesis in the liver, spleen and lymph nodes. It may be primary or secondary to polycythemia vera and essential thrombocytosis. What is the pathophysiology? I have told you that there are JAK2 mutations or MPL or CALR mutations, and these lead to increase in the PDGF and cytokines. Platelet derived growth factor and cytokines, and when released then these cause fibrosis of the bone marrow and extramedullary hematopoiesis starts because bone marrow is unable to produce the cells. Therefore extramedullary hematopoiesis starts. It occurs in the liver, spleen and lymph nodes. Clinical features. What are the signs and symptoms patient present with? First one is patient is mostly over 50 years of age and there may be fatigue due to anemia because red cells are produced less by the bone marrow. Furthermore, there is abdominal fullness and it is due to this massive splenomegaly due to extramedullary hematopoiesis. And also patient has less satiety because this large spleen compresses on the stomach. The patient also has bleeding due to low platelets because bone marrow is fibrosed and unable to produce the platelets now. There may be hepatomegaly, and hepatomegaly is also due to extramedullary hematopoiesis, and the complications of this are ascites, portal hypertension and development of the esophageal varices that bleed. There may be myelopoiesis in the epidural space, and this epidural space myelopoiesis leads to development of transverse myelitis, a condition that is mostly characterized by paraplegia, spastic paraplegia. What are the labs? First one is CBC. CBC shows anemia. There may be thrombocytopenia, or initially there may be increase in the platelets. And also there may be decrease in the WBCs, or WBCs may be high or WBCs may be normal. On peripheral smear you will see teardrop red blood cells, teardrop red blood cells, nucleated RBCs that are called erythroblasts, and myeloblasts are also seen in the peripheral smear, and it is called leukoerythroblastic picture. This is highly suggestive of this myelofibrosis when there is leukoerythroblastic picture and teardrop red blood cells and giant degranulated platelet forms. So triad of teardrop red blood cells, leukoerythroblastic blood picture and giant degranulated platelet forms on the peripheral smear. This is triad. On bone marrow biopsy you will see that there is dry tape and there is increased reticulin fibers on the bone marrow, and that is bone marrow is replaced by the collagen fibers. There is bone marrow fibrosis. Treatment. In asymptomatic patients we observe mostly, and supportive care is initially required. While the patients are if symptomatic, for example patients have anemia, then we go for RBC transfusions as required. And if there is large spleen, then you should go for hydroxyurea. Hydroxyurea is given as 500 mg twice a day, and it decreases the spleen size. Spleen size is decreased. Furthermore, if the splenomegaly is refractory to these treatment options, then we go for splenectomy, especially when there are increase in the transfusion requirements, and due to large size of the spleen there may be splenic infarction leading to pain, and it is an indication for splenectomy. Radiotherapy is given for bone pain, and ruxolitinib, it is a JAK1 and JAK2 inhibitor, and you know that there is JAK2 mutation in the myelofibrosis in almost 50% of the cases. So when there is JAK2 mutation, then you should go for ruxolitinib, and it is given when hydroxyurea doesn't work, and it leads to decrease in the spleen size and also improvement of the symptoms. Ruxolitinib, JAK1 and 2 inhibitor. And if all these treatments do not work, or if the patient is higher risk at high risk disease, then you should go for hematopoietic stem cell transplantation.